Good afternoon, everyone. You're very welcome, and thank you for attending today's webinar. I'm Amy Casey, and I'm the Communication Manager for Endo-ERN, and I would like to thank you for attending, and of course our speakers and chairperson for making this webinar possible. A few housekeeping items before we get started. This webinar is being recorded, and it will be available on the Endo-ERN YouTube channel within 48 hours of this event, should you like to share it with your colleagues or review for your own personal use. In addition, you'll have an opportunity to ask questions to our expert, and we will take the questions at the end of the presentation. So if you have a question, please use the question panel on your control panel, and Professor Lacic will put them to Professor Husebye. If you prefer to put the question directly yourself, please raise your hand and I will unmute you. You will be muted for the course of this webinar. This webinar was actually organized by Endo-ERN Main Thematic Group 1, and we're delighted to have Professor Lacic, who is the chairwoman of this MTG. And she's going to very kindly introduce our speaker and get us started. Over to you.
Thank you very much, Amy. Good afternoon, everybody, and good afternoon and welcome to Professor Eystein Husebye. And I would like just to introduce you with a few sentences. Professor Husebye is a professor and consultant at the University of Bergen and Haukeland University Hospital in Norway. He has had a long-term interest in autoimmune endocrine diseases and specifically Addison's disease. He has also built up a very large national registry and biobank for Addison's disease with many hundred, maybe 1,000 patients almost since 1996, and has coordinated several European projects within these research topics. So please, Professor Husebye, welcome.
Thank you very much for this kind introduction, and welcome everybody. Good afternoon. Today's topic is adrenal insufficiency, and I'll take you through some diagnostic procedures and how to treat these patients, and try to illustrate this by some cases. So, leaving this beautiful picture of my hometown, Bergen, we'll start on the first case. So this was a case of, it's a case of Addison's disease, but this started with a young boy, 2 years old. He got type 1 diabetes and was followed up at the children's department. And then a couple of years later, as part of an annual screening, it became apparent that he had 21 hydroxylase autoantibodies, but he had a completely normal adrenal function. They also did a synectin test at the time. But then several years later, he turned up again, didn't feel well. He had a yellowish skin color and actually was quite hyperpigmented, as shown on these pictures. And he was very fatigued. And when the lab workup got back, it became apparent that he had a low sodium. He had normal potassium, but cortisol was low. This is nanomolar per liter, and the ACTH was very high. The upper cutoff is 11. He also had low aldosterone. He had a little bit elevated renin, but he also had very severe primary hypothyroidism with elevated TSH and low free T4. And he also had TPO antibodies and also TSH receptor antibodies. Ultrasound revealed thyroiditis, and a synectin test revealed no increase in cortisol. So he was diagnosed with an autoimmune adrenal insufficiency and also autoimmune thyroid disease. Family history revealed that his mother had type 1 diabetes from 9 years of age, and his maternal grandmother had adrenal insufficiency. Starting a bit late. So this case illustrates several key points. You can get autoimmune endocrinopathy at many different ages in early childhood and later, you can get several diseases, and they tend to aggregate in families. This shows data from the Norwegian and Swedish Addison registries that actually over half of the patients have another organ-specific autoimmune disease. Type 1 diabetes in about 12%, pernicious anemia in about 10%. Also, gonadal failure is quite prevalent. Actually, the number is around 10 to 12% in Norway, at least in a recent survey. And about 6 to 8% have also celiac disease in the Norwegian registry. So you can have several autoimmune diseases. The problem is, since this is a rare disease with about 20 per 100,000 in prevalence, it's difficult to pick it up and to remember the diagnosis. So fatigue is very common, loss of appetite. What is quite typical is this salt craving. Because they lose sodium in the urine, they tend to eat a lot of salt, chips, licorice to try to compensate. But you have to ask for that symptom. They also have postural dizziness because they have low blood pressure, and they have this typical hyperpigmentation that you showed. So that's kind of a giveaway. Not only the skin, but also the mucous membranes can have this hyperpigmentation. Can you get some clues from normal kind of common blood test? Well, we did a survey among the Norwegian and Swedish patients and discovered that hyponatremia was very common at diagnosis before treatment was started. 84% had hyponatremia, but the less than half of the patients had hyperkalemia. That's kind of what you read in textbook, is low sodium, high potassium. But many of these get acutely ill just before they are diagnosed, and many of them were diagnosed as part of adrenal crisis. So maybe they have thrown up and lost potassium. So don't look if they don't have high potassium, they could still have Addison's disease. And half of them had also elevated TSH. One of the reasons for that is low cortisol leads to an increased TSH and can be misdiagnosed as a hypothyroidism. And also 10% had hypoglycemia. This is more common in children. So the problem is to think about the diagnosis. Once you've considered it, it's easy to make the diagnosis. Often you get the diagnosis by taking a paired cortisol and ACTH. And these are the cutoffs given in the recent clinical guideline of the Endocrine Society. So you have a high ACTH and a low cortisol. You also have typically a high renin and low aldosterone. And DHEAS is also typically low. If you still are in doubt of the diagnosis, you can do a synactin test. And there are different cutoffs. I think most common in textbooks is 500 or 550. We now did a study a couple of years ago and set the cutoff at 485 using LC-MS for cortisol measurements. But this will vary between labs. Once you made the diagnosis, you have to find out the reason why the patient has adrenal insufficiency. And the first step should be to measure 21-hydroxylase autoantibodies, as autoimmunity is the most common cause. You should have in the back of your mind these other causes, and we'll come back to some of them afterwards. But at least in Europe and North America, autoimmunity is the most common cause. Other places in developing countries with tuberculosis, HIV, AIDS, these causes are probably more common, but we don't have numbers and how common it is. But at diagnosis, actually, this is rather old data, but in my experience, more than 90% have antibodies at diagnosis, if they have an autoimmune cause, of course. Another case, this young man, also got sick at an early age with candidiasis at age 1. And then when he was 4 years old, he came into the ER with acute adrenal insufficiency and hypoparathyroidism. And later he has developed other autoimmune conditions, animal hypoplasia, alopecia, nail dystrophy, malabsorption. And this is typical for the monogenic condition called APS1, autoimmune polyendocrine syndrome type 1. So here are these also other typical manifestations illustrated: the candidiasis, the animal hypoplasia, the alopecia, and the nail dystrophy. So this special type of adrenal insufficiency is caused by mutation in the ER gene, and APS1 have Addison's as one of the main components, but also hypopara and candida, and this patient had all of these 3. But this is a kind of extreme endocrinopathy variant. One gene is mutated and you can get a lot of autoimmune manifestations. Many of these have 21 hydroxylase antibodies, but they also have interferon antibodies, which is a good screening tool. And I'll show you that. Just to briefly say what ER is doing. So ER is expressed in the thymus, and ER facilitates the expression of organ-specific proteins, present them for developing T cells, so that T cells that are autoreactive react against your own proteins. They can be deleted from the immunological repertoire. But if ER is missing, these autoreactive T cells escape to the periphery and can give rise to autoimmunity later in life. So you will recognize some of the same components our first patient and the Addison patients often have, type 1 diabetes, for instance. But you see here that candidiasis, hypoparathyroidism is very common among the APS1 patients. So this is quite rare in Norway, with a population of 5 million. We know about around 60 patients, but it's probably underdiagnosed. And we have these interferon omega antibodies that all of these patients have. But just to illustrate the kind of the spectrum we can see in APS1, this was a 29-year-old healthy male. But he came to the ER with a history of nausea and vomiting for 3 weeks. He had lost 6 kilos. He had a low blood pressure. And when lab was done in the ER, he had a very low sodium, 110. He had high potassium. And later it became apparent that he also had adrenal insufficiency with low cortisol and high ACTH. He was 21 hydroxylase autoantibody positive. But since he was in our registry, we had run interferon omega antibodies also, and they were clearly positive. And it turned out to have the most common ER mutation we find in Norway. So he was an APS1 patient, but starting very late at 29 years of age, looking like a typical common Addison patients. So we were able to make the diagnosis APS1. His sister had hypothyroidism and pernicious anemia, but we haven't been able to investigate her. I'm not leaving here yet, presenting this Finnish family with 2 siblings, 2 sisters who had typical APS1. In childhood, they developed candidiasis, Addison, hypoparathyroidism. And they had the Finnish mutation and another mutation, so they were quite typical. But it turned out that one of these women had a son who developed severe pernicious anemia in childhood and also vitiligo. And the maternal grandmother also developed pernicious anemia. These had only one of these mutations, and it turns out that you can develop Addison's disease and also endocrinopathies with only one mutation in ER. So to make a long story short, we characterized many of the mutations in EAR, and in this particular PHD1 domain, there are many mutations, and if you have one of these, you can develop endocrinopathy, looking like a regular Addison APS2 patients, but it's caused by the mutation in EAR. So there are a number of these mutations, and these are dominant, autosomal dominant inheritance, so they can aggregate in families. And if you look here, this is from the original publication. They less often have interferon antibodies, they less often have hypopara and Addison and candidiasis, but many of them have vitiligo and B12 deficiency, pernicious anemia, and some of them have no phenotype. So it's a milder kind of disease. But these mutations are relatively frequent, 1 in 1,000, carry a potentially dominant EAR mutation. Finally, I want to present the GWAS we published on Addison's disease a couple of years ago, and that showed that EAR also plays a role for the common Addison's disease. And one of the loci that came up in the GWAS is a coding variant in EAR, affecting not the PHD1 domain, but the PHD2 domain. And it's predicted to be pathogenic. So it seems when it comes to EAR that you can have 2 mutations, have the classical APS1 childhood start most often, but not always. You can have 1 mutation in this particular domain, and these patients can develop Addison in adulthood and look like APS2 patients. And you can have a variant in the PHD2 domain that's quite common in the population that increases your risk of developing Addison's disease. But not all patients have antibodies, and you should be aware that especially in the older generation, old people and children, they might have another cause of adrenal insufficiency. So this is from a published review in the Lancet listing all the causes. I won't go through them, just to illustrate that there are a huge number of causes, and if you don't have an autoimmune cause, you should try and go through the list. And if it concerns a child, you should look for genetic causes. If it's an older person, you should consider hemorrhage maybe, or malignant disease, but won't go into that. But just a few more cases. This was an old woman. She had had recently knee replacement surgery, and after surgery she developed atrial fibrillation and was put on anticoagulation therapy. Then she developed a sepsis, and because of a rapidly developing hyponatremia, a younger doctor at the ward thought that maybe there was a cortisol deficiency here. And indeed, she had Addison's disease or adrenal insufficiency. She did not have antibodies against 21-hydroxylase, and we then did a CT that revealed enlarged adrenals, and turned out that she had bilateral adrenal hemorrhage causing her adrenal insufficiency. And you should be aware that when this hemorrhage is an acute event, and these patients can then go into an adrenal crisis, but they are not hyperpigmented. So even if ACTH is elevated, there hasn't been enough time for hyperpigmentation to develop. So she had a bilateral adrenal hemorrhage. This is another patient. He was diagnosed in childhood. He had a history of hyperpigmentation, salt craving, weight loss. But when I saw him in his early 20s, he also had a mild hypogonadism, a hypogonadotropic hypogonadism with low testosterone and low normal gonadotropins. He had an interesting family history because his brother had died 8 years old, and it turned out that that was because of an infection and an untreated adrenal insufficiency. And also his mother's brother and cousin also had Addison's disease and hypogonadism. This is the family tree with this young man I mentioned. And here is the mother's brother and the cousin, and the deceased brother. So 4 males in this family with adrenal insufficiency and hypogonadism. He was 21 hydroxylase negative, so that talks against APS1, and the inheritance looked like it was X-linked, so it's also not typical for APS1. We also screened other antibodies that were negative. So adrenal leukodystrophy is one disease you should then consider. It only affects males, and that fits here. It's a defect in a gene called ABC1 involved in fatty acid transport in the peroxisomes, and you can measure these ultra long, not term, chain, it should be ultra long chain fatty acids, and you can sequence the gene. And an MRI may reveal leukodystrophy changes, but our patient did not have neurological symptoms. He also had normal, very long chain fatty acids, and the sequence was normal. But then another cause that also shows X-linked inheritance is DAX1 mutations. Dosage-sensitive sex reversal, adrenal hypoplasia, critical region on the X chromosome, protein 1. Mutation could fit with this, but again, it turned out that sequencing of the DAX1 gene was negative. But then our geneticist didn't still believed it could involve DAX1. To make a long story short, it turned out that upstream to the gene in the enhancer region, there was a big piece of DNA that had flipped over and destroyed the enhancer region. So DAX1 was probably not expressed in this patient. So this was a DAX1 mutation after all. So we have made a diagnostic algorithm. If you have primary adrenal failure or insufficiency, your first step should be the 21 hydroxylase antibodies. If that's positive, you might be finished, but is there an unusual phenotype? Is there an animal hypoplasia problems, for instance, hypopara, candida? Consider interferon omega antibodies, and it might be an APS1 patient. And then, if possible, confirm that by sequencing the ER gene. If the antibodies are negative, the next step should be an adrenal CT. If it's a male, you should do the very long chain fatty acid for the diagnosis of adrenal leukodystrophy. A CT may reveal an infection like tuberculosis, a tumor, or bilateral hemorrhage. You can also have hyperplasia if it's a CAH, but that's usually apparent, especially in females. Or it can be an idiopathic PA, but then you should consider doing a whole genome or exome sequencing and look for some of the other rare types. We have now the Norwegian and Swedish Addison researchers have developed a polygenic risk score also that we hope will be useful in the clinic. Published recently in Journal of Internal Medicine by Dr. Aranda Guluen, who defended her PhD actually today. So what about treatment? You made the diagnosis, then you want to treat the patient. So the real treatment revolution was in 1950. That's when cortisone became available around well, in 1948 actually. So this was before that a deadly disease, but after this time point, it became a disease where people could survive on cortisone. So that was what the real treatment revolution. And most of the patients use the same treatment today, hydrocortisone, twice or thrice daily. In some countries like Norway and Italy, cortisone acetate is still used. It has about the same pharmacokinetics as hydrocortisone. Maybe it works a little bit longer. So I think there are things that talk in favor for cortisone acetate, but the standard treatment is hydrocortisone and 15 to 25 milligram. You may use a weight table to dose, and the pediatricians of course always looking at the weight or surface area when they dose. I think the adults are not so don't do that so often. They should probably do that more often, but you can use a weight table like this. But the last couple of years, the more treatment options have come available. So the thinking behind the hydrocortisone, the traditional, is to give the highest dose in the morning when you have the circadian top or high levels of cortisone, and then you give a lunch dose or an afternoon and maybe an early evening dose to try to mimic this circadian variation. We have now for at least 10 years have had Plenadren. That's a slow release. I'll come back to that. You give it only in the morning. You get a surge and then a slow decline, but you can take it once a day. Recently, Kronokort, or it's registered now as FMODI, has come available. It's also a slow release, but it's also a delayed release. So you can take it in the evening before bedtime and then another dose in the morning, so-called toothbrush regimen. And it's registered for treatment in CAH. And finally, you can also infuse hydrocortisone subcutaneously using a pump, an insulin pump, for instance, and I'll comment a little bit on that. So we usually start with hydrocortisone or cortisone acetate as our standard treatment. About 20 to 25% of the Norwegian patients also use Plenadren. That's more convenient, and it's once daily. Studies have shown that Plenadren treated patients have a bit lower blood pressure and the weight tends to decrease a little bit. They also have in studies a slightly lower HbA1c. So, but this is a more expensive treatment and depends on the country you come from, if it's reimbursed or not. I think that's maybe the main thing steering the use of Plenadren, but there are some metabolic factors in favor of Plenadren. Kronokort has this maybe mimics physiology a bit better because you get a rise in cortisol during the night, which is what normally happens. And it has shown be effective to suppress androgen levels in CAH patients. Personally, I don't have so much experience yet, but we have treated a few patients and some of them got insomnia probably because of the cortisol surge in the night. So you might have to tweak the doses and the times depending on the rhythm, daily rhythm of the patients. But if you look at the normal cortisol rhythm, it's not only a circadian rhythm, it's also a ultradian rhythm. So ultradian rhythms are rhythms with a frequency of less than 24 hours. And you see here that this is a patient that's in a hospital research unit and taking blood samples continuously, and then you can get these fine curves where the ACTH surge followed by a cortisol surge. And you see the peaks are higher in the morning and lower in the evening. And you have the nadir when you come to the bedtime here. So this is what we really aim for in treatment. We want to try and mimic this. What we have done in collaboration with Karolinska is to try out continuous subcutaneous hydrocortisone treatment. This doesn't replicate the physiology because you're not replicating the ultradian variation, but you can replicate the circadian rhythm, and you can then bring down the ACTH because you cannot use ACTH to monitor a patient on tablet treatment because it's varying all the time and often is high. But with the pump treatment, you can actually use the ACTH level as a biomarker of the correct dose. So we did a study. We had quality of life as endpoint and could show some improvement in quality of life. Others have not shown that, but we didn't pick out the patients who had the worst score in quality of life at the beginning, and probably if we had done that, we might have seen bigger differences. But we have in Norway about 20-25 patients have been on pump treatment for many years. And for some of these patients, this has been a real game changer. They've been not able to work, and after starting pump treatment, they can enter professional life again. So for some patients, this has been really a game changer. For others, it doesn't make much difference, but it's good to have in the toolbox if you're unable to find a therapy that works for the patient. So what we do in practical terms, we take hydrocortisone and put it into an insulin pump, and 1 unit on the pump is 0.5 milligram hydrocortisone, and then you just program the pump. They are even able to give extra doses as a bolus, just like you'd give a bolus of insulin. And then we usually do a cortisol curve and also measure ACTH to try to tweak and get the right dose and replicate the circadian variation. But how should we monitor the treatment? We don't have a HbA1c for cortisol, unfortunately. So you have to rely mostly on clinical findings and symptoms. You can do lab tests, of course, but they are not very helpful. What we do is we check kidney function. We do sodium, potassium to see that they are within range, but they are not very sensitive. They are not sensitive enough to use it to adjust doses. And we do quality of life. There's a disease-specific, Addison-specific quality of life questionnaire that you can use, but usually you have to talk to the patient. I see there's a slide missing here, but it's important to ask the patient how is his daily rhythm, how is his morning, is it difficult to wake up, does he have down periods during the day? So sometimes you have to adjust the timing of the doses. We have patients using 4 doses of hydrocortisone per day, 4 small doses, and some people think that is okay. Others do very well with 2 doses. You have to really individualize the treatment and try to give as low a dose as possible without any symptoms of adrenal insufficiency. So while we 15 years back had a average dose in Norway of 40 milligram cortisone, I believe we are now down to 30 milligrams on average. So I think if you have focus on dosing, you should be able to give a lower dose. And most of the Plenitrin treated patients use 20 milligram hydrocortisone in Plenitrin. But can we really replicate this ultradian rhythmicity, and why is it important? Well, if you look at these are cell studies and animal studies, you can see large differences in gene expression, whether you expose a cell for continuously with glucocorticoids or if you pulse them with glucocorticoids. So this pulsing high and low levels of cortisol is probably important for how glucocorticoids exert their function in the body. A recent study was published by Georgina Russell and the team in Bristol, where they are trying to replicate physiology by pulsatile treatment, and they compared this with the standard tablet 3 times per day. And they did this in 18 Addison patients and 4 with CAH, and did a battery of tests on these, and I'll only show a few data on that, but they saw especially the ease of awakening from sleep was much better on the pulse pump, behavior following wakefulness, so they felt better in the morning, they had less physical and mental fatigue, and they did also many advanced psychometric tests, facial recognition tests, and so on, and also functional MRI showing some changes in the amygdala region. And Professor Lila Lajic is more an expert on that. But this was kind of an exploratory study, and I think it's a line we should pursue and see if we can improve replacement therapy. We have in a EU project developed a technique to, sorry for my voice, okay, thank you. A new way to monitor or measure steroids, doing that in the subcutaneous tissue. And this is you pump a buffer in this semi-permeable catheter. So while it's here in the subcutaneous tissue, it equilibrates with the tissue fluid, and you can then collect the fluid in this urethrum sampler and sample subcutaneous tissue fluid for 24 hours and analyze up to 20 different steroids. We published this earlier this year. The normal range of 200 healthy subjects using this technique, but just showing one example from an Addison patient where we can monitor the tissue cortisol levels, and here 10 milligram was given, here 5 milligram, 10 milligram, 10 milligram cortisone. So you see after you give the dose, you get a surge in tissue cortisol. You can also measure cortisone simultaneously. And what's quite interesting in this patient that his cortisol is rising here in the late night, even if he hasn't taken a tablet. So this patient has a residual adrenal function, just to illustrate. But to summarize, primary adrenal insufficiency is difficult to recognize. It's a rare disease, but it's easy to diagnose once you thought about it. Consider it as a differential diagnosis. Paired cortisol and ACTH usually gives the diagnosis. You can do a synectin test if this is not clear. the first next step should be measure 21-hydroxylase autoantibodies, and if they are negative, you should go on with a CT of the adrenals and targeted testing depending on the age and the phenotype, other hints in the patients, maybe, and sometimes next generation sequencing is also necessary. When it comes to treatment, there are many options. Conventional hydrocortisone and cortisone acetate is still the most common treatment, but there are slow release formulations available. Plenodren, that's been around for more than 10 years, and also the recent new drug FMODI, and pump treatment is also possible for the very selected cases. When it comes to monitoring, we don't have an HbA1c. I missed a slide showing some day curves of cortisol in either saliva or serum, but sometimes we use that just to see that the patient that is on a quite high dose has a normal absorption of cortisol, so that you see they are in the reference range at least. So it's not a very precise tool, but at least you should sometimes we check if they really absorb the cortisol properly. And you can also use quality of life questionnaires or your own questions. The future, maybe pulse pump treatment, at least for some patients, will become an option when this has been studied more. Tissue cortisol profiling might be an option. At least the technology exists. Maybe there are people working on trying to develop real-time cortisol measurements, like real-time glucose measurements, and maybe we can have a closed loop pump in the future. I don't know. Thank you for listening.
Thank you very much, Professor Husebye, for this excellent lecture with a lot of clinical applications and descriptions of patients. Do we have any questions from the audience? Do we have anything in the chat? I don't think I can see anything in the chat yet. So I think I could ask a question. You're talking about the pump treatment, and how common is it in Norway to use the pump?
Well, we are now checking how many we know about, around 25, and we have around 1,000 patients with adrenal insufficiency. So the problem is actually the patient organizations are asking for pump treatment for their members. There is a problem because Sulocortef has only after you break the capsule and dilute it's guaranteed for 24 hours. So that means that if you want to go by the book, you should
change the ampulla once a day. Yeah.
Once a day. Makes it very tedious and expensive. Before they did it every third day, which was much more practical, and some continue to do that, but we cannot endorse that. So it's a bit tricky, but now Pfizer has actually asked us to review our experience, and they might consider to change the warranty.
Okay.
So I think it might become more common in the future when also the pumps are, many of them use the Omnipod pump.
So the type of pump is an ordinary insulin pump?
Yeah. Doesn't have to be an advanced one.
Yeah. And you were talking also about the polygenic risk score that was recently published. But how common is it that if you have a true autoimmune Addison's disease, not to have antibodies at diagnosis?
I think we looked at that 15 years ago when we did our first national survey, and we found that those who were diagnosed the last 5 years, that was 20 patients, 19 of them had 21 hydroxylase antibodies. So I think at diagnosis, the autoimmune, they have, I think it's over 90% are positive. So I think it's quite rare to...
It's rare not to have antibodies at diagnosis.
If you wait, the number of positives will decline, but if they have a very high autoantibody index, they will be positive 40 years later. They never get, but those who have a lower index tend to go down below the threshold. So,
yeah, but still it takes 10 years or so.
Yeah, so within 5 years, the autoimmune should be positive.
Should be there, yeah. So if you're negative and you have primary insufficiency, you're negative. So what would actually the polygenic risk score give you extra? Isn't it just to go for whole genome sequencing, and then you will find the monogenic, most probably
I guess
cause of it?
The easiest would be to do, and that's what the geneticists do. They do an exome or a whole genome, and then you can, I guess, quite easily extract the polygenic risk score. And if it's high, you might argue it could still be autoimmune for some reason, because few things are 100%. But is it low? It really should encourage you to look for other causes. And I think now that whole genome sequencing have been becoming cheaper and more available, I think we will find new genetic causes of Addison's disease that maybe look like the autoimmune phenotypically, but have another cause.
Yeah, or very much milder phenotypes of different serogenic disturbances and other nuclear transcription factors and support and so on. Yeah. Okay. Any other questions?
Don't be shy.
Nobody? Did I have anything else I was thinking of?
It's probably your experience too. There are always patients that are difficult to treat, and so. But most you have to be patient. You have to really ask them, take a good history, and sometimes it's relevant to check the absorption of.
Yes.
It might be an undiagnosed celiac disease.
Yes, definitely. Thank you very much, Professor Husebye, for being here with us today and sharing your experience and knowledge. And thank you to the audience. And this webinar is closed. Thank you very much for being here.
Okay.